Thank you a lot, and welcome to everybody to what I think is one of the most important sessions we had in the last years within EESO. I want to welcome Dr. Cafarotti from the Ticino, who's very close to Italy, and as everybody knows, there is a lot going on, and this tsunami of coronavirus is coming in. So we are eager to hear experiences in Ticino. For our side here in the French-speaking part of Switzerland, it's rather calm, I would say, and also Alexandru Eniu is here, who joined me in Rennaz, and we will try to give you some yes news or advice, practical advice for the treatment and for the follow-up of this patient, of the cancer patient with this coronavirus. So there is not a lot data about this because it's rather rapidly it came rather rapidly, and there are lots of things who are not clarified from the beginning. And so data are coming now in different journals, and we try to summarize this a little bit. Um, the agenda will talk a little bit about the individual risk of patients without cancer, also about the risk within the healthcare workers, because this is important. Um, then Stefano will take over to talk about the specific risk for cancer patients and the consequences. I think this is important and the major part of our discussion. And then Alexander will take over with some practical issues, and then will have a discussion at the end. But don't forget, you can put questions in whenever you want, also during the talk, and we will have enough time at the end to try to answer and discuss all your questions. So if we see the mortality within coronavirus from the first data who appeared in China, then we can see that it's really something serious. We look up in the aged person, starting with 50, we have anyhow 12 to 30% of patients who die from this disease. And these are not cancer patients, these are not fragile patients, because I think, and we have to estimate that in this patient population, it's even higher, the risk to die from the corona. For the healthcare worker, I think if you applicate the measures that are already also recommended by the WHO and by different organizations, the risk seems to be not so high. So we are there at 0.5%, and this is rather okay, because we have to say that there is the fear that healthcare workers are more infected by coronaviruses being exposed to them. We have to be cautious because probably in China the measure works very well, and so these numbers are also probably not up to date anymore, and they can change from week to week. This is a table from the appendix of the publication in Lancet Oncology. I think Stefano will go through it more extensively, but in the appendix there is this table who shows us in a logistic regression model the odds ratio for patient with cancer, who is practically the highest with 5.399, going from the lower limit from 1.8 to 16. And it's rather huge. And this shows really that our patients, the oncological patients, are at a very high risk. If we see again the table that I showed you before, so we have a really high risk, even more probably for the cancer patients. And as you know, in Italy, the situation is dramatic. And even to start to do some triage within the patients to decide which patients are allowed to go to intensive care units. Is it the patients who are in palliative treatment or curative treatment? Are these the younger patients or the older patients? These are very difficult decisions, because if you look, then we see that even in the younger patients, there are not much patients dying of it. And so we have to ask if it's really the correct, the right procedure to go and save this one and let the others alone, and probably also die a lot. Because if you want to save lives, probably the target population is not even the youngest patients, but also the fragile one, and there the measures had to be taken. And to comprehend more about this, Stefano will go through that and to try to give you some hints who will be important also for the discussion thereafter. So Stefano, I give you the word. And thanks.
Can you hear me?
Yes.
Okay. Good evening, and thank you for the kind invitation. I think that all of us know that we are in front of a serious situation with a never know disease in a pandemic context. And when we speak about this new disease, coronavirus disease and cancer, we still have probably more question than answer. So still more question than answer. And today I try to answer to those specific questions that could change cancer patient daily management. The first one is COVID-19 more incident in patient with cancer. Are there more severe events like admission in intensive care unit, invasive ventilation, or death in cancer patient? And the most important for the moment, should we avoid oncological treatment during pandemic situation? So, like my colleague say, we have just one publication that appeared in February on the Lancet Oncology. Is a national analysis in China on 1,590 cases with confirmed coronavirus disease. Of those, 80 patients had a history of cancer, and with this volume of data, the author concluded patients with cancer had a high risk to develop COVID-19. I have four points to discuss that I think is a bias of this publication. First is that we have not enough data to conclude that patients with cancer had a high risk. Probably, as my point of view, the incidence of coronavirus disease in patients with cancer would be more informative. And with small, simple sites presenting as a various cancer type with different biological behavior, highly variable disease course, and diverse treatment strategy may be filled with contingency and thus not ideally representative of the whole population with cancer. Another point is that an half of population, 9 patients with cancer, had a disease course of more than 4 years, indicated probably that a substantial proportion of these patients may be clinically cured. Last point, 72% of patients, means 30 patients, with cancer had a history of surgical resection. And comparison of patients with coronavirus and surgical history with and without cancer would be of interest. It's clear all of us know that immunosuppression, chemotherapy, or immunotherapy or surgery play for sure a role in this new disease. But for the moment, I think that any conclusion that generalized to all patients with cancer should be taken with care. I think that scientific community have to focalize urgently on this topic, and I'm sure that they are doing. But from the same analysis, we can conclude a little bit something with more power, I think, because that population, also if it's proportionally small, have a high risk to develop severe events. So when we try to answer to the second question of my presentation, we can say that patients with cancer have 5 times more risk on respect of normal population to develop severe complication. So we have an increased rate of admission in intensive care unit, need of invasive ventilation, and major proportion of death. So the central question is, should we avoid oncological treatment during pandemic situation? I think that all of us, surgeon, oncologists, physician in general, have to manage in the hand 2 different risks for the moment. in one hand, the risk of cancer progression if we stop any oncological treatment, and in the other hand, the risk of infection if we go ahead with our oncological treatment. So I try to balance both risks with some data, and we have all take in consideration when we deal with the risk of cancer progression, the epidemic curve. Probably we are just at the beginning of this coronavirus disease. And if we take a look at the curve of China, probably we have in front of us 3 months in a best scenario, or in a worst scenario, according to some voice coming from UK, we could be we could have the possibility to manage the situation of coronavirus in our hospital for 1 year. So we cannot stop for sure treatment for 1 year. It's exactly what we want, is to pull down the curve and manage the coronavirus for a long time, just to prevent, to fulfill all possibility to treat patients in our hospital. But when we take a look in the other end at the risk of infection, we have to consider the population at major risk, the 5% with a critical course, and with a 50% with the severe course, that is exactly corresponded to those patients that was considered frail because elderly, or frail because they have concomitant comorbidity, so with 1, 2, or 3 disease. And cancer appear in this data, so we have certainly considered cancer as a risk factor. So I try to manage and deal with the risk of infection in our clinic with my colleague in a multidisciplinary setting. Risk of infection for those patients that need oncological treatment. So we establish new way of treatment, new space with dedicated hospital for COVID and dedicated hospital for other treatment. We avoid the visit for family in hospital, our patient. We promote strongly patient protection and staff protection, and we reduce for the moment all other unnecessary activity. And then also to focalize our attention on the intensive care unit admission, we select according to European criteria by Brunelli, and to experience in our clinic with the multidisciplinary in a multidisciplinary setting, those patients that could be treated by thoracic surgeon without the necessity to move in intensive care unit, but just with a bed. And I think this is a very important topic if we want to go ahead with the surgical resection of early stage non-small cell lung cancer. That is a specific population in which, if we solve the problem, we have not to treat any longer with chemo or radiotherapy, and probably surgery must be included also during coronavirus disease and pandemic, like a treatment of choice for early stage non-small cell lung cancer. It's different if we have to deal with risk of progression for those patients frail with high risk of infection or very elderly or elderly. We actually have 2 meetings in video conference. It's a multidisciplinary meeting with oncologist, pneumologist, thoracic surgeon, radiologist, nuclear medicine doctor. And we are speaking in a very open discussion also with patients, the personalized treatment. Like first step, we discuss patient wish. It's very important also in this context. Then we discuss to start a sort of follow-up, 1 month, wait and see up to 3 months before a final decision. We are exactly into the storm of this coronavirus at this time in the southern part of Switzerland. So we want to take a look at the pandemic curve, and probably in 3 months we can propose to our patient the gold standard. We will see. But we are also in open discussion to prolong neoadjuvant treatment, to not perform adjuvant treatment in a specific subset of patients, to promote stereotactic therapy and not perform surgery. And we are really in open discussion because we have no guideline, and all of us, I think, in this period have to use ethic and common sense. Thank you very much.
Thanks to you, Stefano, and thanks for the clear presentation. There are a lot of questions coming in. Before I pass you the first, who's directed directly to you, I want to answer probably one who refers to lung cancer. So the question is, I think that the population of patients with cancer who had poorer outcome at lung cancer were smokers. Can you confirm? So as you remember, my table, this an annex table, appendix table from the Lancet Oncology was exactly like that. So the COPD patients and the former smokers, they are really at risk. So at the end, we have anyway a virus who's attacking the lungs, and this is the part who's the more in danger part with the RDS and causing death at the end. So yes, for smokers, these are not good news. The second question, and this is for you, Stefano, what do you mean by staff protection? Test all patients, protect with FFP3 or 2 masks, triage all patients with symptoms?
So at the beginning, we triage patient with just 4 symptoms. That mean fever, cough. That is the principal symptom in which every hospital triage this patient to select where they have to go in a specific rule, or so that mean in a clean hospital or in a COVID hospital. Actually, we ask also if the patient have a history of cancer. That means if patient have this symptom of history of cancer, we put a mask. This is a protection for patient. And for hospital community, we promote to put mask every day, in every situation, in outpatient and in inpatient situation, but it's surgical mask.
Thanks for the answer. I think we continue with Alex's talk, and then we have the other questions that will be addressed at the end.
So I guess my talk is related to not so much to the science of how to deal with the coronavirus, but rather how the community, the oncology community, is reacting, and what are the first recommendations on what should we do on a daily basis. And I put this up because, of course, the WHO has issued some recommendations. They are non-specific for cancer. There's nothing specific from cancer coming from the WHO, but I think their website is a good reference for many measures, and they had many missions going to Wuhan. So information on general attitude towards patients, or indeed how to prevent people from becoming patients with coronavirus, can be found there. So while searching for the literature, there are some organizations and some hospitals which start to give some guidance. And just to pick an example, this is something that I took from the Fred Hutch Cancer Center in Seattle. Basically, they resume the presentation that Stefano made on the data that we had, saying that patients with cancer have higher risk for major complications, which was already said, and the highest risk seems to be in patients with hematologic malignancies, the ones that are under active chemotherapy in the bone marrow transplant patients. And as Stefano already and actually Marco presented, half of the cancer patients in the Lancet study had a higher risk of severe events, and this needs to be clarified, how much we can rely on just 18 patients and how much information can we extrapolate for our patients. But in general, a patient with cancer had poorer outcomes, and has been discussed. Now, in Italy, seeing what is happening, I think it's remarkable in a way that the health minister have issued some recommendations which are specifically directed to cancer patients during the pandemic of COVID-19. And just, I think this is, I read the document, and just, I think it's useful information saying that actually the risk for hospitalization is greater, probably 4 times greater in cancer patients versus the same age group that do not have cancer. And this is greater, and most of the patients that were hospitalized in Italy were within 1 month from surgery or chemotherapy. I think they made some recommendations on how to triage the patients, and take this with caution. The recommendation that the health minister in Italy made was to maintain treatment, to maintain the dose intensity for patients receiving chemotherapy or immunotherapy. But of course, this has to be taken into consideration, and there are not so many diseases for which there is a proof that maintaining dose intensity can be efficient. However, the idea behind is not to compromise the oncological pathway just because of fear of the coronavirus. I think this is important. I think, and I will talk a little bit later on that. I think what is relevant for us as health professionals dealing with cancer patients is not only how to deal with the patient in front of us, but actually how to better organize our work and to make sure that we are here for enough time to take care of our patients, which means we have to protect ourselves and protect our patients from becoming infected as they come into the hospital. I think so. One of their recommendations was to establish separate circuits and waiting rooms for patients receiving treatment, which makes a lot of sense, and postpone non-urgent visits for patients off treatment. And I guess these are recommendations that now you can see on some other organization like the NCCN. They published an article recently in their journal summarizing some ideas related to treating cancer within patient with coronavirus. I think that, and this is just a plug for you to go on the ECHO website to actually read a statement on COVID-19. I think attention, their main message is that attention is urgently required to protect cancer patients and preserve healthcare professionals, scientific and patient societies. But go ahead, read this, and you will see what can be done at the European level, or should be done at the European level. So unless we have published guidelines, I think we should use common sense, and now evidence is becoming more and more evident to try to guide a little bit our activity, both in terms of organization and also how to deal with the patient. I think one important issue is to inform and prepare the staff working in the service. On-time information and communication with team is crucial to keep everyone up to date and to actually be able to manage within the context of a changing situation that can affect what we do from one day to the other. I think that it is important for the well-being of the team to actually have a meeting to, as we do here at Marcus Organizing, to discuss with the staff if the staff has symptoms or sickness or the logistical problems. I think it's very important for us oncologists to have a procedure for suspected cases. These cases are coming, and we all will have them. And you have to have a procedure in place in order to know exactly where to take the patient, what to do, and what are the next steps. One thing that has been discussed is to limit the presence at our meetings. We all have tumor boards. What we are doing is to just send one representative from the team and try to do it with that. And but when we go towards the patient, I think One obvious thing is to try to select the patients that are requested to visit the hospital. And this can be done by the treating senior staff who knows the patient. He knows the patient, he has some criteria to judge the decision, but at the end is we have to take into consideration the age, the patient age, the curative or palliative setting. But I think bottom line is that it's reasonable to postpone routine follow-up visits and do it by phone or telemedicine and concentrate resources to treat those patients that really need attention and really need oncological care because of some sort of an emergency. And I think coming up towards how to select, what to do with the patient that we are currently treating. I think one message that comes very clearly, probably also from most institutions that had done something like the Cancer Care Ontario, for instance, or even ASCO, they published a frequently asked question list on their website, and other institutions. It is important to initiate or continue systemic cancer treatment than to delay or interrupt the treatment due to concerns about potential, due to fear about the infection. I think we have to consider and use our clinical judgment to prioritize and do what is best in order not to compromise the oncological outcome of the patient. For that, I think we should take into consideration the prognostic of the patient. What is the chance of the therapy to really help them? For sure, and we'll get there. It's a difference if we do the treatment in adjuvant or palliative care, but there is no external help for the moment. There is no evidence that use of prophylactic antiviral therapy is of any use for our patients. There is no evidence that says that we should stop or should change the type of chemotherapy that the patient is receiving just because she might get infected with the coronavirus. And I guess when it comes to decision, we have to do what we should do always, individualized treatment decisions. It's clear that, for instance, if you are having a patient which is undergoing a treatment for, I don't know, metastatic testicular cancer, you will not delay that kind of treatment. But perhaps if you do it, if you have a patient for which a palliative chemotherapy is administered with not much benefit, and in a patient with a lot of other symptoms, you might consider not bringing that patient in because the benefit of giving another cycle of whatever chemotherapy we're providing or immune therapy might not justify the risk. However, for in the curative setting or in the even adjuvant and neoadjuvant setting, I guess we need to individualize the clinical decision, and we should not compromise the potentially large benefits. I had the patient actually that she had her third cycle of neoadjuvant chemotherapy for breast cancer. It was a don't stance because it's a triple negative, and we continued. We continued the treatment because although she was somehow asking what should we do, so I think around this area, I just made some comments, but of course we are all here to answer the questions, and we have a lot of questions. So I think I'll stop here with a presentation, but we can discuss during the discussion.
Well, thanks, Alex. It was very clear, and as you said, no, there is not a lot of guidance, but anyway, there is common sense, and we have to organize a little bit our units. Yes, and as you said, also is very important. So we have the resources for the moment now. Perhaps this changes in the next weeks, and then perhaps you have reconsidered some things. Sure. But for the moment, it's clear curative treatment. Every treatment goes on. The follow-up visits are not there, and then we have to reschedule probably after that. There are questions, a lot of questions coming in. We are gonna address them all. One question was if oncological patients should be tested throughout. Even if asymptomatic. I wouldn't test them all, I have to say, because probably even in the oncological patients, it's not that everyone goes to die. So at the end, we have and probably also their patients who just have the corona and do quite well. And the other thing is to declare a patient symptomatic in a cancer situation is also difficult, because if I see the waiting room of today, probably 1/3 of the patient had symptoms who define in the normal population already a COVID infection suspect. So at the end, this is also very difficult. And that's the reason why anyway, we have to be careful. We have to select well already on the phone. We have to call the patient. They have to call us. And so we can triage already there to see which ones are the patients who are going bad, and then know the patient, as you said, palliative treatment, curative treatment, neoadjuvant treatment, younger patients, older patients, and then decide personalized also there from patient to patient.
We got a question about what about cancer survivors. I guess the evidence that is there is that actually there is nothing more to say. I mean, cancer survivors are considered not at higher risk for COVID infection. The higher risk is for patients that are currently under treatment.
Absolutely, I agree. I think also there, survivors, even if they call, they have to be reassured. But for them, the rules that are applied and recommended by the WHO, they are in act anyway. So if they have symptoms, if they have known persons who they were in contact with, they're at risk, they get dyspnea, so they have to come to the emergency department, to the ERRs, and then we do the tests, and then the other colleagues will take over it sometimes. What's perhaps critical in the cancer patients, and I think in this Lancet Oncology paper it was delineated. So in the moment the patient really got to the intensive care unit, he gets intubated. So things look rather bad, because the extubation is really something rather rare, as I also saw in the last report from Italy. So this is not good to get there, and there we should select well and treat somehow aggressively. So perhaps the antibiotics, even if it's not recommended, if you have the suspect of a superinfection, perhaps you have to treat early on with them, even steroids. You know, many patients nowadays, they have immune therapies. So even there, the distinguishment between a corona infection or a toxicity from an immunotherapy is not so easy. So steroids could anyway save them, even for the corona. We don't know too much, but in the moment he gets really bad and the patient gets intubated, we have to try that, I think.
There was a question that I think it's for Stefano. Why do you think neoadjuvant longer is safer? I think it came quite at the beginning. Maybe it's just because delaying surgery, but I'll let Stefano deal with that.
Yeah, I think that when we discuss about the best solution, we have to consider the time on the curve, epidemic curve, pandemic curve, where we are. For the moment, if you have to deal with possibility to manage patient in every other field in intensive care, I think you have to propose the best treatment. But when you have full capacity reach in intensive care, when you perform, for example, after neoadjuvant treatment, a pilobectomy or a sleeve resection for lung cancer, and you have no possibility to move patient in a postoperative setting in intensive care unit, this is the reason of why, in a personalized manner, probably is the time in Ticino or in Italy to prolong for one cycle the neoadjuvant treatment before the definitive solution, because we have actually, or we could have early no capacity to move patient in intensive care.
Thank you, Stefano. Thank you, Stefano. There's another question here. When the demand to offer treatment exceeds the capacity of the treating unit, how should treatment be prioritized? Patient with metastatic disease, symptomatic versus patient with early ER-positive breast cancer with small benefit of adjuvant therapy. I guess everybody is thinking about that, and I don't think there is a simple, clear-cut solution. This is, in the end, this will be a political decision. Someone will have to take this decision. For the moment, if if I am the one taking the decision for my patient, and if I have to prioritize the number of patients, it's clearly defining what is the benefit that the patient gets. And so if I have to choose from one patient who's deriving benefit for his metastatic disease, rather than to give the same, let's say, bed for chemotherapy to a uncertain small effect on chemotherapy. I mean, this is the things that we will have to do. So this is what I was saying: individualized treatment decision thinking, how we can do our best to make the best outcome for the patient. And there's no simple solution. If we want a simple solution, we'll get a political decision who will say, but other than that, we will have to weigh in all this information that comes from the patient and be really honest with ourselves and with the patient in the end, what we can offer versus what can be offered to another patient. I don't know.
And that's absolutely correct, because at the end, and there is the other question that goes in this line a little bit. So the question is, continue all cancer treatment to all COVID negative patients, introduce therapy to newly diagnosed patients. If you have a patient who's aged and he already declared you don't want to have treatments who prolong survival and stuff like that, you have to remark it in your chart. And this is an important information for the colleagues in the ER department when they come in the patient. So probably if they are well followed by the supportive and palliative care units outside the hospital, you can take care of them by distance, perhaps give advice by telemedicine and not let them come to the hospital. Otherwise, if you have, as you said before, a younger patient doing curative treatment, you have to do everything you can to get the patient safe and cured. And then it's a question of resources. But for the moment now, you cannot deny a patient a curative treatment or to start a curative treatment because of COVID. You cannot do that. And anyway, again, even if the risk is rather high, there is the patient who will not have be affected more than that with the coronavirus for the moment, as we know. And so the other question was also if there are more neutropenia or febrile neutropenias that we observe. For the moment, we don't have the numbers to say anything, but I don't think that this is the issue. So the febrile neutropenia is not something described in this over 1,000 patients in China. So this is chemotherapy induced. It's clear that if you have a metastatic disease, a palliative treatment, and you have to think about forcing the treatment anyway, because probably we overtreat also a lot of patients. And so it's important to talk to the patients before the situation comes in about intubation or not, emergency room or not. And this has to be really clarified beforehand. Also to know in the moment that resources get rather small, what we have to do and to do a better triage from the beginning. Yes.
Yeah, I mean, I got a direct question. If I think that immediate breast surgery might be better than neoadjuvant chemo for operable patients, well, I mean, I don't. I think that we should continue what we planned, unless the patient has clear evidence of infection. I mean, in that case, she or he goes on the immediate pathway. But I don't think that just because of fear of COVID, we should, in this moment, alter the oncological pathway of the patient and do something just because we think to change our mind. If a decision was made to do neoadjuvant treatment, I think that decision was well taken, and then you should continue on that direction.
Yes, and then I think, as you mentioned also, there is from department to department, there are differences. I don't know, probably a transplantation department or an immuno-oncology unit has another cancer patient good than we have in a rather normal outpatient ward. And just to show you, the animation doesn't show very well, but it's clear. If you have a separate entrance, you can do a lot of benefit because the patient just go through his flow, he gets out rather early, he's not exposed to the other patients. After that, everyone is now washing his hands and putting on masks, and then you have perhaps a fire door who you have to activate by your hand, so you have to disinfect this or let the doors open and wait between the risks. And so there are a lot of measures. And everything, every time I see a recommendation of this kind, and then I think about, yes, don't touch this, don't touch that, and then everyone is going to the water dispenser and drinking water. And so it's really something who keeps there. And we know now from the New England publication from yesterday, I think, this corona is still there after hours, and so we get infected anyway. I think the pandemia now is there. We get exposed to the virus. We have to well select the patient on risk and do a good triage from the beginning, already for the resources, because as you saw, there is not a problem of which nation. It's really a problem of how you organize and how you flatten the curve at the end, and how you applicate the resources you have. And if you don't have enough respirators, it's clear that there will be a moment where you have to do a triage. It's good to be prepared already now. Perhaps to Stefano, because Stefano, you are a little bit nearer the front than we, so it's not Lombardia and Italy, but your wave is already there. What do you recommend to all the others like us who are just waiting for the tsunami? We see it coming, but it's not already here. But perhaps you have good points to tell us.
First, the social distancing, also in between doctor, and this is very important. Just
we have
is an example.
But the cam is too close. So
yeah. No, I think that we have to prepare all to this tsunami in a good way, means with plan. A good plan. We have to select and triage patient and completely agree. But I think the problem is principally for intensive care unit, and select patient for surgery could be a problem. Select patient for oncological treatment in that subset of patient, very elderly with comorbidity, could be a problem. We all are waiting the results coming from literature, but for the moment I sponsorize a lot the personalized medicine. So I suggest to speak a lot in between different professional partner in the decision to the best oncological treatment.
Thank you.
I mean, I don't know how much time we have. There are many questions. I think we will not be able to answer all of those. One question is, do we introduce therapy to newly diagnosed patients? I think, again, here it depends what is the issue. If the benefit is large, if adjuvant treatment, potentially curative, or if it's immediate need for symptomatic disease, yes, again, I mean, a priori, I would not exclude anyone from treatment. Just considering the situation and applying treatment. If benefit is not so sure, then we or you have other measures that you can institute. People can be postponed, but not without taking into consideration all the consequences of that. And I don't think we should propose universal COVID screening to all oncological patients, because this, even in a rich country like Switzerland, I don't think this will lead to a good outcome for the patients. It will certainly induce a lot of stress. And there was another question relating, what do we do with the psychological stress? I think it's difficult. We have to use the resources, our psychologists, but people are not used to deal with this kind of or this kind of situation, more other cancer-related issues. So offer needs to be made to the patient.
Absolutely. And the other thing is, okay, we have many oncological department has a psycho-oncologist on the ward. So at the end, we can offer that. And the other thing is, be there for your patient. Take the phone yourself, calm them down yourself. It's not the other staff or the secretary doing that. It's really talking to us, do the triage, calm the patient down. That's the thing who can be done. Well, one very interesting question, I'm afraid we won't have the answer, is how do you treat COVID-19 infected oncological patients? Are they treated by the oncology team or no, sorry, this wasn't the question. The question was if there is some hints that with immunotherapy, PD-L1 or PD-1 antibodies, if this is something to consider, if it's more dangerous for these patients under this treatment or not. This is a rather interesting question, because I think we don't have the data. We don't know. But this is very important because immunotherapy, as you know, can enhance the immune system. That's exactly what we don't want to have in IRDS or cytokine storm was killing the patient. So this is a rather good question. I would be very cautious on that. So I think if there is a patient with immunotherapy coming into the ICU, whatever, then probably in that moment I would stop treatment and anyway discuss with my colleagues from the intensive care unit to start steroids anyway, because I think in the RDS, it is this immune response who is dangerous for the patient. And so I would stop the immune therapy. But I don't know, Alex, if you have some hints, but for this situation, we really don't know.
No, I think I really don't know, and I agree with what was said. I don't, I cannot add on that. I think even, I mean, different recommendations regarding TKIs in terms of continuation of therapy. I don't think we don't have any data on that either. I think that, so use your common sense. I would say probably for the TKIs it should continue the therapy, but no one knows in this moment.
Perhaps we prolong a little bit for some questions, around 10 minutes we have still, and a very important question is also here, how do you treat COVID-infected oncological patients? Are they treated by the oncology team or transferred to the infectious disease specialist? And here the answer for me is clear, it should have both. So the oncological advice is important, but it's clear we are not used to treat viral infection. There are the specialists for that, and it's okay that they take over. But the oncological input is rather important. And as you know, there are also treatment in discussion, how to treat, let's say, end stage or really, really dramatic situations like that. There are antirheumatoids who are in discussion, tocilizumab. There is a huge study opening in Italy and one already open in China. Perhaps this is a good thing. We don't know, but it's clear we have to be in contact because the cytokine storm and the reaction on the COVID is very similar to a lot of toxicities we saw with immune therapies. So probably also for the infectious disease guys or for the intensive care guys, just to ventilate the patient with this very dismal prognosis is not the only thing to do, and we should really talk to each other and have guidance as soon as possible from studies or from experience. So I think also from Italy is a lot coming in from the intensive care specialist. I saw publications. So to have some advice, what it's the best to do. And this is not something we can wait for data in 6 months and see what was the best thing, because in 6 months, probably we have our deaths and we have to decide rather rapidly. And this is also a question if our scientific publication world is up to date for a situation like that. Probably we need platforms online, perhaps a forum like this one, to discuss and see already data generated by the colleagues who are in the front.
Absolutely. I mean, there was a question regarding, do you have selected centers where oncological COVID patients are treated? Not yet, but there are, in Italy, there are some centers, as I understood, that in the end, they received a little bit more patients with this type of concomitant problems. And those will be the ones to be able to report on some data. But again, as Marco was saying, rapid ways of spreading the information are key, as we would need to use that information long before we have the time to really print it.
Well, thanks again, Alex. I don't know, Stefano, do you have some remarks? Otherwise, we take perhaps 1 or 2 questions before closing the session.
We can take questions.
Okay, thank you. So I saw a lot of questions about TKIs and other targeted therapies. So even there, it's clear you don't have hints about the risk with corona. Probably we will have when it is too late. But for me, it's clear if you have a metastatic lung cancer patient, is doing Tagrisso, and this is the medication who's saving his life, because we are talking about a palliative treatment, then I won't stop this treatment because I know what's coming out if I stop the treatment. So I continue the treatment. I want to treat the symptoms from the COVID, or at least try or speculate on that he will never really have serious events from the COVID. And so I won't stop even the TKI or antibody treatments who are not somehow also immunotherapies. Well, then I think the most important questions we answered. I don't know if you see anyone who's still there. Rotational system for work for oncology. So there is a question: have you in your institution introduced a rotational system of work for oncologists? That's a good point. So for the moment, we don't have, because resources are limited, and I think in every country the positions are counted. So we don't have 3 or 4 staffs on the back end, but it's clear that we thought about this for the next weeks, and it's clear also that a lot of staff will get COVID positive, and in that moment we will have some shortages. So the recommendation to delay follow-up visits, not to start treatments who are really necessary for the moment, is important also because of that, because I think whether you have a rotational system or you are quite you have cautious for your staff is anyway important, but we don't have it because we are also not a huge team with 20 to 30 oncologists probably there with some residents. We can think about a rotation. I think there could be some possibilities like that. Anyway, if the situation gets dramatic like in Italy or in Ticino, I think you cannot allow just to have some rotators at home. So they will be needed at the ERs and other sites, other services, intensive care, even on the inpatient ward to give advice, to do tests. And so I think we are not we have not the luxus to have rotations for that reason too. Okay, so I think perhaps if you see another question we didn't address.
Will you consider vaccinations as pneumococcus?
Pneumococcus, yeah. So I think pneumococcus is rather a good thing for patients who are at risk for infections. Yes, to vaccine now, I think I wouldn't do it, because after that you just don't know why the patient is coming in. Is feeling fluid or something, then you don't know what to do. This is rather something I wouldn't do right away for the pneumococcus. I think it's too late at this point. But as you know, if the curve is flattening, perhaps there is a recommendation coming out. If you wait for data on that, you will probably never have it. And that's the other point. So then I think we are at the end. I want to thank Stefano, first of all, from Ticino. That was very interesting and for us important to have this exchange. And Alex, thanks also for this special EASO session. What we want to try to make is another breaking EASO session next week on the COVID-19, perhaps with some other experts who will tell us a little bit more about trying to treat the disease, or how it's best to treat in the moment it gets serious. And this will be shown you in the media, and we will advertise it. And at this point, I want to thank to the audience. It was a huge audience today with a lot of questions. I hope we addressed almost all of them. Thanks a lot. Take care, and take care of your patients. Seeing you next time.
Bye-bye. Thank you very much.
Bye, Stefano.
Thank you very much. Bye-bye.